Welcome to the clinical refresher for a cross-table lateral hip radiograph. This module was written by Susie Mosley, B.S., RTR, and Megan Lemp, B.A., B.A. After completing this module, you will be able to describe the patient preparation requirements for a cross-table lateral hip projection. Explain how to position a patient for a cross-table lateral hip examination. Summarize the technical settings and patient instructions necessary to produce a diagnostic image. Identify major structures seen on a cross-table lateral hip radiograph. List the evaluation criteria used to determine image quality. The axiolateral projection of the hip using the Donnelius-Miller method is more commonly referred to as a cross-table lateral or surgical lateral projection. This projection uses a horizontal central ray and can be performed if standard positioning for a lateral hip projection is contraindicated due to trauma or pathologic factors. If a patient has an implanted orthopedic device, it must be imaged in its entirety in this projection. Clear communication with a patient will ensure that a proper patient history is acquired and that the patient will comply with all instructions. It is generally good practice to explain the procedure to a patient before exam positioning so that any questions can be answered immediately. When examining the pelvis and hip, it is especially important to advise the patient of palpation methods that will be used to localize anatomic structures before positioning begins. Patient history should include a discussion of any known anatomical variants that may impact the exam, as well as any medical devices implanted in the area of interest. For example, technical factors will need to be adjusted if a patient has a joint replacement or severe arthritis. Patients should remove clothing and jewelry in the area of interest and should be provided with a gown to provide privacy and prevent the patient from getting cold. Positioning for the axiolateral or cross-table lateral projection begins with the patient lying supine on the radiographic table or stretcher with the affected limb extended. Have the patient place their arms in a comfortable position outside the field of view. The patient's pelvis might need to be elevated using a positioning cushion or folded sheets so that the most prominent point of the greater trochanter can be centered to the midline of the image receptor. When elevating the pelvis, make sure the positioning cushion does not extend past the lateral aspect of the hip so that it will not impede positioning of the image receptor. Place additional cushions under the affected limb for support. To raise the unaffected leg out of the field of view, have the patient flex the unaffected hip and knee until the thigh is nearly vertical, then rest the foot or lower leg on an appropriate support device. Make sure the device does not interfere with the path of the X-ray beam, but do not use the X-ray tube housing or collimator for support. Make sure the patient's pelvis is not rotated. Unless contraindicated, rotate the affected leg and foot approximately 15 to 20 degrees medially to position the femoral neck parallel with the plane of the table. If needed, place a cushion under the knee and a sandbag over the ankle to help the patient maintain the correct position. A physician should manipulate the affected leg if a patient has an unhealed fracture. Turn the image receptor vertically and position the top of the image receptor against the patient's side in the soft tissue crease that forms above the iliac crest. Angle the bottom of the image receptor away from the patient's body until the long axis of the image receptor is parallel with the long axis of the femoral neck. Ideally, a vertical image receptor holder or sandbag is used to hold the image receptor in place, but the patient can also hold it in position if necessary. Make sure the grid is positioned with the lead strips oriented horizontally to prevent grid cutoff. The central ray is directed perpendicular to the image receptor and the long axis of the femoral neck entering the groin midway between the anterior and posterior surfaces of the thigh. It passes through the femoral neck, which is located approximately 2.5 inches or 6.3 centimeters distal on a line drawn at right angles to the midpoint of a line between the ASIS and the superior margin of the pubic symphysis. Anatomical markers are placed on the image receptor to identify the anatomical side that is being examined. Instruct the patient to hold very still, and the exposure is made on a suspended breath. Attempt by 12 inch or 24 by 30 centimeter image receptor is used for a cross-table lateral projection of the hip and should be positioned lengthwise. The SID should be set at a minimum of 40 inches, although some departments may require a longer SID. The collimation should be adjusted to 10 inches by 12 inches. Use of a compensating filter is strongly recommended to improve detail on the finished image. 90 kVp is a common setting for a cross-table lateral hip projection performed with a grid. Common mass settings are 32 mass when using digital radiography and 71 mass when using computed radiography. A large focal spot should be selected. A cross-table lateral projection of the hip will show the femoral head, femoral neck, greater trochanter, lesser trochanter, and the acetabulum. The ischial tuberosity is also seen. The following quality criteria should be used to determine if a cross-table lateral hip radiograph has been produced with proper positioning and technical factors. Collimation does not obscure relevant anatomy. The hip joint and acetabulum are displayed, and the femoral neck appears without overlap from the greater trochanter. A small portion of the lesser trochanter is visible on the posterior surface of the femur, and a small portion of the greater trochanter is visible on the anterior and posterior surface of the proximal femur with proper femur inversion. The ischial tuberosity is visible below the femoral head and neck, and the soft tissue shadow of the unaffected thigh does not overlap the hip joint or proximal femur. Orthopedic devices, when present, are visible in their entirety, and soft tissue and bony trabecular detail is well visualized. This concludes the clinical refresher for a cross-table lateral hip